Hi, I'm Dr. Kevin Knopf with the Philip R. Lee Institute for Health Policy Studies. I'm a hematologist, oncologist, and division chief at Alameda Health Systems and affiliated with the IHPS through the Department of Medicine at UCSF. My main areas of research are cost effectiveness in hematology and oncology care. I think about this a lot. The reasons I think this is important is because of the way American healthcare is sort of paid for, which doesn't make clear economic sense, and that has some real negative repercussions for patients. There's a old joke about engineers that optimist thinks the glass is half full, a pessimist thinks the glass is half empty, and an engineer thinks the glass is twice as big as it needs to be. And I think that's the way health economic works in America. Part of the reason that this is an important thing to think about is that we have a lot of patients in America who are uninsured or underinsured who can't get care. And in my field of oncology, some of these patients can't get curative chemotherapy or curative surgery because of the nuances of how healthcare is paid for. We have some alarming statistics. We have now that 50% of women in America with metastatic breast cancer are being pursued by debt collectors. So, what I like to think about is ways to look at cost effectiveness of cancer care. That includes chemotherapy, which is what I do day to day, but also imaging, radiation, monitoring, procedures, and surgeries, and try and optimize that so that patients can get the best outcome at the lowest cost to the healthcare system. So, the perspective of society, of the payer. What's transpired, not just over the past couple of years, but obviously over the past 20 years, is that a lot of the racial and ethnic disparities in cancer care have to do with health economics. So there's a couple reasons why we have racial and ethnic disparities. Some of it are social determinants of health. We have cultural literacy issues, and we have sort of subtle or overt racism, but a lot of it has to do with health economics because there's a big difference between how healthcare is paid for in the public system, Medicaid and Medicare, and in the private system. So, what we like to think about is cost effective approaches to hematology and oncology care. We do a lot of cost effectiveness analysis and cost modeling. And then there's a newer phase of this called de escalation of care, which means can you get the patient to the same outcome clinically with actually doing less? So health economists will sometimes say health is more. There's a lot of ways to do this type of work. There's a lot of retrospective database analysis. We're now in an era where people talk about value-based healthcare and value-based cancer care, which is going to be more prospective changes. So that requires sort of a good understanding of where you can get to what place while spending the least amount of money. So I find this area of research fascinating, and I think it has a lot of practical implications for patients in the American healthcare system.